Hello, everyone. My name is James Doyle. I'm a second-year internal medicine resident at Baylor Scott and White in Temple, Texas. And on behalf of our research team, thanks for tuning in today. I'm sure we're all too familiar with the grim prospects associated with pancreatic cancer. This can be a particular challenge when treating elderly patients because they are more likely to develop the disease, but also because of other comorbidities and sometimes less than ideal performance status. It's important to know more about the treatments that we may or may not choose to subject them to. To help fill in this knowledge gap, we conducted a unicentric retrospective review to investigate the outcomes of pancreatic cancer in elderly patients. We studied patients aged 65 and up who were seen, diagnosed, and or treated at our facility from 2008 to 2019 and obtained various details about their cases. Our primary outcome was overall survival from the time of diagnosis, and then we'll break this down further. We used a predetermined p-value of 0.05 to indicate statistical significance. And what did we find? Well, our initial search turned up 665 patients with a median age of 75. Of these, 291 received at least one dose of chemotherapy. The median overall survival of those who received chemotherapy was over 2.5 times that of the patients who received best supportive care alone. This difference was consistent both among the younger half of the age group as well as the older half. And what we'll see here on the next two slides is that patients with both lower stages of cancer and higher stages saw benefits to receiving chemotherapy. Additionally, even patients with elevated Charlson comorbidity scores, and by proxy, we conclude poor functional status, saw benefits from receiving the chemotherapy. The most common chemotherapy regimens that we encountered were gemcitabine-based, usually either as monotherapy or in conjunction with paclitaxel, and 5-fluorouracil, usually as part of FOLFIRINOX, FOLFOX, or FOLFIRI. And while the latter tended to outperform gemcitabine, this tendency did not meet criteria for statistical significance. Last year, a similar review was published out of Brazil, and we obtained comparable conclusions with their study, showing that chemotherapy patients had an average overall survival of 8.1 months in our study versus 7.8 months in theirs. Finally, we did not find the same statistically significant increased survival from FOLFIRINOX as in the Prodigy trial from several years ago. Though, interestingly, in the Brazil trial from last year, they did have an overall survival with FOLFIRINOX in elderly patients that was better than that of the younger patients in the Prodigy trial. So it is still entirely possible that the elderly, like their younger counterparts, can have a benefit from receiving FOLFIRINOX over other regimens. Our study does have a couple of potential shortcomings, chief among them being our reliance on proper EMR coding to help us obtain our data. And in conclusion, it does seem that elderly pancreatic cancer patients may benefit from chemotherapy in ways similar to their younger counterparts, and it is reasonable to offer it to them in accordance with their goals of care. With that, I'd like to thank the members of the American Pancreatic Association for allowing us to present our findings, especially those who worked so hard to make this year's conference virtual. I'd also like to thank my faculty mentor, Dr. Wong, and all the other members of our research team listed here. Thank you.